And gosh, it takes a phenomenally long time to upload to YouTube. I'm not sure why, but so I'm uploading right now. There's probably one more. There's probably one more being uploaded at the moment, or if it's not just finished, and then I'll continue to get a move on, especially these, because you have a test on Wednesday. So we definitely want to make sure the thyroid and parathyroid is up and ready. Let's get slightly closer. Okay, so with the parathyroids, guys, we usually don't even see them. They are absolutely tiny. They are isoechoic. They sit, for the most part, just like this picture over here shows, they sit behind the thyroid and they are flattened out. So it makes it really hard to see them. But it's good to know where they usually are. They're not always exactly as shown here. Remember, this is the backside view. This is not a front view. This is the backside of the thyroid. There are usually 4. Let's get the color here. There's usually 4 parathyroid glands. 2 are posterior to the upper poles, and then 2 posterior to the lower poles. They are small, 1 by 3 by 5 millimeters. So at the most, 1 by 3 by 5. Now, personally, I would do 5 by 3 by 1 because it's length, width, height, not height, width, length. That's just backwards. But so 5 millimeters long, average. So that's, that's only half a centimeter. They're really small. Like I said, difficult to see if normal. They're isoechoic to the thyroid, so makes it even harder to see. They could be slightly non-isoechoic, probably a little hypoechoic, and then we have a chance on seeing them. They're flattened posterior on the posterior surface. So when flattened, I mean they are, for the most part, shaped like that, and then thyroid gland is on top of it like that. And so tricky to see. They can be ectopic, and they follow the same ectopic route as the thyroid. It's a similar distribution. So let's use this picture up here. So they could be, instead of being right here and here where they're supposed to be, they could be up here, all the way to the base, pretty much the base of the tongue, just like thyroid. And then they could be farther down, all the way down to the thymus gland. The thymus is down here in the middle of your chest. It's not really used in adulthood. It's more of a, dang it. Come on, baby. Come on. Oh my God, this is the hardest control. All right. So ectopic distribution similar to thyroid. Well, that means, of course, they migrate down. Almost always when you have an ectopic organ, it's because it migrated in utero. Supernumerary glands, usually like one more, so like a 5th gland, are possible. And if you do have a supernumerary, it's probably right about here, little farther down. So that is possible as well. Here's a great picture of a parathyroid gland, super small. Here's the thyroid. And this is a sagittal view. I don't know if it's right or left. It really doesn't matter. Little strap muscle on top there. The sternocleidomastoid mastoid up here, strap muscle there. But in any case, this one is a little easier to see because it's, rather than being back here where we usually see them, it just traveled just a slight bit farther down. And so we're able to see it separate from the organ, or separate from the thyroid, You could imagine if this guy were slammed up in here, pretty much impossible to see. So don't worry about not seeing them. We always try to see them. Always pay attention, because if they're enlarged and they're like right back here, then you want to know, is that part of the thyroid gland, or is that part of the, or is that like a adenoma on the parathyroid? So, okay, physiology. You've got one job. Don't screw it up, parathyroids, but they do, and sometimes that's we'll get a parathyroid exam, and actually they just order a thyroid exam and then say special attention to parathyroids, and it'll be for hypercalcemia, too high a calcium level in the body. So they activate the osteoclast. I couldn't remember the other day if it was osteoclast or osteoblast. They do opposite work in the bone. These are the guys, these are the little cells that travel around your bone, literally eating your bone up. And then the osteoblast comes in behind them and lays down new bones. So your bone over time is completely replaced by the osteoclasts and osteoblasts working in unison. And so if they activate the osteoclast, that means they work a little harder. They dissolve more bone, and that releases more calcium into the blood. I'm sorry, I jumped over PTH entirely. PTH, parathyroid hormone. And that's the one thing these guys do. Parathyroid hormone also increases the absorption of calcium by the gastrointestinal tract, GI tract. It also increases renal reabsorption of calcium. So remember, in the kidneys, you know, you have this the tubules here, and well, also you have the glomerulus up here, comes down to a tubule like that, and all that fluid comes out and then it goes back in. So huge amounts of H2O, water, and some little proteins and ions and calcium and all that stuff goes out, and then it goes back in. And so with renal reabsorption, calcium is 2+, I think. Calcium is reabsorbed back into the tubules at a higher rate. So GI and renal are, well, the GI draws more calcium in from what you eat. The renal reabsorption makes sure that you don't expel through your urine too much calcium. So that's what that does. I think I said that right. I know I said it right eventually. It's just... So just like everything else, and I've drawn my 4 little parathyroids here. Parathyroids, there's a negative feedback mechanism. Works 24 hours a day, 7 days a week throughout your entire life. These 4 or 5, but 4 guys, they put out parathyroid hormone into the blood. It stimulates the bones, the kidney, and the GI tract, all to increase the serum calcium. Serum meaning blood. So it's increasing the amount of blood, or the amount of calcium you have in your blood. With that increase, then parathyroid hormone will slow. So it actually, the parathyroid increases calcium, and an increase in calcium in turn slows it down. When that slows, the calcium is lowered. When it's lowered, we start pretty much going right back. So this is a continuous circle of PTH increasing calcium. Once it's increased, the PTH slows. The book doesn't mention this, but I kind of thought it was important. There is this kind of its own circle here, but it works in conjunction with the thyroid. Remember, the thyroid had calcitonin. Calcitonin reduces it. It draws more calcium back into the bones, or allows the kidneys to expel some calcium rather than take it all back in. So when we have an increase in serum calcium, in that case, the hypothalamus sees that it tells the pituitary gland. The pituitary gland tells the thyroid, hey, release calcitonin. So that also works to lower the calcium. Of course, now with lowered calcium, parathyroid hormone increases. And so, yeah, we could have drawn this as two different circles. We could have drawn this as one circle, because really now we're getting back into this circle. Does that make sense, guys? Where I'm parathyroid hormone is, let's do this one over here as well. Calcium is, if it is low in the blood, parathyroid hormone is released. And increases calcium. That in and of itself slows parathyroid hormone down. But on a parallel track next to it, or a parallel circle, it also, when we have an increase in calcium, it stimulates the thyroid to release calcitonin, which also lowers calcium, which lowered calcium there, lowered calcium there. I'm beginning to think I shouldn't have done two separate circles. I should have done one circle and just had calcitonin in there as a note that it also works on it too, because I'm realizing as I'm trying to speak through this that it could be a little confusing the way I've done this. So if we do think of this as just simply one circle, or if we don't even think about calcitonin at all, we just look at this as a negative feedback system. It's a negative feedback system, and calcitonin from the thyroid works with it. Let's just leave it as that, because I was so happy with my little diagram there until I started speaking about it. I don't like it anymore. So hypercalcemia, too much calcium in the blood. Too much calcium in the blood. That could be simply from hyperparathyroid. The thyroid simply, for whatever reason, so that's a primary issue, primary hypercalcemia. Primary because it starts from the parathyroid. And there's two major reasons for that. There's one that's just a overgrowth of tissue, and then the other is an adenoma. Renal failure. So with a renal failure, the calcium, this whole feedback. I'm sorry, we haven't even talked about the kidneys. Well, we did talk about the kidneys' role. The renal failure, the kidneys do not expel enough calcium. And then vitamin D deficiency. Oh boy, guys, I didn't really understand that. So I cross-referenced it and looked it up. Hypercalcemia, vitamin D deficiency. And there was no, I mean, no simple explanation. The websites like WebMD didn't give you any explanation, and then when you go into actual um, papers about the subject, I mean, what these guys do is just unbelievable. The amount of, you know, feedback loops, and A affects B, affects C, affects D, and blah 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 all the way through Z. It was really very complicated. But in any case, vitamin D and calcium work together. And if you have a vitamin D deficiency, you have difficulties getting calcium out of the blood and back into your bones. So vitamin D deficiency will give you, over time, over given a long enough time, will actually give you brittle bones because you don't have enough calcium in the bones because you have hypercalcemia. That sounds like you would have. It sounds like you would have too much calcium, right? Well, you do. It's just in your blood, not where you want it in your bones. Hypocalcemia is not enough blood calcium in the blood serum, and that could be from an accidental removal, like a thyroidectomy. Let's say the person had thyroid cancer, multinodular thyroid. It was a huge thyroid, and the doctors remove it. Well, the doctors do their best not to remove the parathyroids, but if it's a mess in there, the parathyroids come out as well. Autoimmune diseases, they seem to attack things like thyroids, parathyroids, adrenals, all sorts of our hormones are attacked by autoimmune. And then simple, straightforward, primary hypoparathyroidism. So like I said, we will get orders for these, even though we don't normally see them when there's something wrong with them, then suddenly we see them generally. So with like primary hyperparathyroidism, 80% of the time, you're going to find an adenoma. And it's going to be one adenoma, not 4, not 3, not even 2, one adenoma. So only one of the 4 has an adenoma. And it is a functional adenoma. That's why we have the hyperparathyroidism. Some adenomas are not functional. So you might have an adenoma. It might be a total incidental finding because the person did not have hyperparathyroidism or hypercalcemia, as it were. Adenomas are almost always solid. They only have cystic degeneration perhaps when they're very large. They tend to be hypoechoic to the thyroid. So now suddenly we're seeing a very dark, sometimes even anechoic. So you'll think it's a cyst, or you think it's a cross section of a blood vessel, but it is not. So we always have to double check our cysts. Adenomas are homogeneous, and like I already said, it's a single gland. 10% of the time, it's hyperplasia. So just simply nodular hyperplasia, focal nodular hyperplasia, whatever you want to call it. It's hyperplasia. It's just overgrowth. And that would be almost never a single gland. So it could be all 4, it could be 3, maybe 2, but never just one. Now, these are seen oftentimes with lithium prescriptions. Lithium is a it's a mineral. It's a mineral. You find it in the ground, in the rocks, and it is used for. I didn't write it down. It's an antidepressant. It helps with bipolar disease, so that's why people take lithium. Oh, and men are always the problem. No, that's actually multiple endocrine neoplasia can cause both adenomas of the hyperparathyroid, not to mention the thyroid, not to mention the adrenals and all that. And then also it can cause hyperplasia as well. That's multiple endocrine neoplasia. And then 1%, and yes, I realize it doesn't come up to 100%, I don't care. 1% carcinoma. These tend to be bigger, greater than 2 centimeters. So not only an adenoma or a hyperplasia is going to obviously be larger than normal, carcinoma is going to probably be much larger than normal. Fortunately, it has slow growth. And one way to know that it's carcinoma and not just simply hyperplasia or better yet, because actually we should know it's not hyperplasia. Remember, guys, if it's a single gland increased in size, it's not hyperplasia. It's probably an adenoma. However, if the hypercalcemia is extremely high, very high calcium levels, now the doctor is a little more concerned with carcinoma. That makes sense. Very, very high calcium levels are point to carcinoma more than just a simple adenoma, which will also create hyperparathyroidism or hypercalcemia. Let's just look at a couple of images here. Just two, really, because we already saw the first one. So these are both adenomas. Typical location. Here, this is a transverse view of the right lobe. Here's the right lobe of the thyroid. There's the isthmus. You can barely see the left lobe over here. And it's a typical location. Hard to know for sure that it is a parathyroid because this very well just could be the posterior portion of the thyroid. So hard to know for sure. But if their blood work shows hypercalcemia, then you say, okay, probably a parathyroid. This one down here is interesting. So once again, hypoechoic to the thyroid, so more likely an adenoma. In fact, I should have gone and grabbed the picture from Friday. And this one's an adenoma as well. I looked up hyperplasia, and all I got were pages and pages of adenomas. So I don't know why that happened, but being hypoechoic, mostly homogeneous. There's a few things that are going on in here that, but this one has a little cystic degeneration here. And so for an adenoma, that we don't see those a lot, but still, this was proven to be an adenoma. You guys remember that picture I had yesterday where I didn't notice it until we were actually talking, not yesterday, Friday. The person there was a thyroid, and then as we're looking at it, I suddenly realized that there was this fairly for a parathyroid, it was a fairly large parathyroid. It just happened to be perfectly isoechoic with the gland, with the thyroid gland. And so I speculate that that would be hyperplasia. Okay. So, wow, yeah, we are flying. Thank God I prepared the next chapter, at least most of it, not all of it. The neck. Now, you could be looking at the neck because that's simply the protocol. Protocol for thyroid, or thyroidectomy. They've had their thyroid removed, and if you're going back and looking at it, it's probably because they had it removed because of cancer. So anyways, neck. We can find dead center, midline, a thyroglossal duct cyst. The thyroglossal duct goes from the base of the tongue all the way down to really to the bottom of your neck, all the way down to the bottom of your neck. And that is where the thyroid, the parathyroids, even the thymus, all traveled from up in the base of the tongue. They traveled down through the thyroglossal duct. In utero, that duct was supposedly completely closed off, and so it should be completely obliterated. But sometimes it doesn't. So we find these thyroglossal duct cysts. Most of them are superior to the thyroid and inferior to the hyoid bone. So that doesn't give us a lot of room. That goes from basically the Adam's apple, top of the Adam's apple, all the way down to the thyroid, which is only about an inch or two. Most of them, they can be higher, they can be lower. And I couldn't believe, your book read that the cysts form could be, you know, in childhood, young adult, older adult, and I found that very strange because most of the time when you have a ductal cyst like this, whether it's a urachal cyst from the bladder to the belly button, it is there from birth because it failed to close in utero. It was there in utero. It is there your whole life. And I did actually have it confirmed that cyst formation can occur later in life. So that is actually true. They're not 100% sure why or what causes it, but they also can be infected, and which might very well be the reason why they're coming in, is for an infected. Shoot, I forgot to get a picture of a early embryo. Because the next cyst we want to talk about is the branchial cleft cyst. All right, this is going to be really bad because I don't even, let's see. 1, 2. Okay, that's early embryo with a lot of butt. But anyway, it's gonna be a big booty embryo. The branchial clefts, the branchial ridges are these things. What these do is they grow on either side of the embryo's future face and neck. They grow together and they come together in the middle of the face. People who have cleft lips, that's because the branchial ridge didn't quite make it all the way, and you end up with a cleft lip. And there's a whole lot of actual facial anomalies occur because these guys will grow together from the right side to the left side and meet in the middle. with a lot of facial anomalies by incomplete or even overgrowth of those. So let's see, this is the first. The second cleft right here may get a little pocket where it kind of basically, it should be obliterated, but it's not. A part of the arch, and this, the arch is the going in part of the arch gets kind of trapped, and it's just very similar. Yike. Very similar to the thioglossal duct. Doesn't obliterate. The branchial cleft is kind of the same thing, except the arch gets trapped in there, and fluid along with it will get trapped. The branchial clefts are always a lateral. If it's actually the first ridge, let's move up a little bit. If it's the first one, this is first, and the arch gets trapped, that actually will get, it's higher up, and in fact will give you a cyst either just outside of your ear or maybe even inside the ear along the ear canal. So if that one gets trapped, the second is the one that we're concerned about. Something like 95% of all branchial cleft cysts are from the second. That one is going to be in the neck, lateral, never midline, it's always along the side, is anterior to the sternocleidomastoid muscle. And if it doesn't create a cyst, if it's even worse, it could actually create a fistula to the skin. So deep in the neck, all the way up through the skin. So every once in a blue moon, a baby is born with a little hole in the side of their neck. And that is a branchial cleft that simply, I don't know, failed to form correctly. And in fact, we have a couple of pictures here. This is probably a kid, because they're looking at what the heck is that swelling. Interesting. So I read that they're always anterior to the sternocleidomastoid muscle, but you know what? That's sternocleidomastoid there, and this is obviously the cyst here. And then down here you see the the bifurcation. Bifurcation. I almost said CCA and jugular, but they're both round, so that means they're both arteries. So it's got to be pretty high up in the neck here to find the bifurcation. Anyway, this is a branchial cleft. This is an ugly, I'm going to write that down, ugly. It's filled with all sorts of stuff. I don't know that it's infected, but this is a thyroglossal duct. So this one is this is a sagittal picture. The one down here was transverse. This one's sagittal, and I know that one because they're saying cranial here, and there's a hyoid bone, and this is caudal, so it's got to be a sagittal picture. So this one, instead of being between the hyoid and the thyroid, which is going to be down about here, we'll say our thyroid is there, and we find most of these cysts in here. This one's just a superior, just cranial to the hyoid bone. Oh, in any case, Just going to be a harmless cyst. Okay. You might be asked to look at, and I don't know why you would, but, or the person just might have one and you need to know, cystic hygroma. We kind of talk about these more next semester in OBGYN because we see these in utero. We see these with trisomies, 21 and 18, 21 being that's Down syndrome, and Turner syndrome. Cystic hygromas are the failure of lymphatic drainage. And so remember our lymph system, you know, so I can't do it with this pen. Our lymph system starts in the capillaries. It's a separate tubes. And then they go and they get larger and larger, and they go to lymph nodes, and they get larger, and they continue on and eventually drain into the veins, actually bilaterally on our subclavian veins. But if there's a failure in these tubes, you know, if they don't go all the way, well, then you get basically a cyst filled with lymph. Amazingly, a lot of times these things just figure themselves out. The cystic hygroma will actually go away on its own. So somehow the connections are made. By far, the most common are the occipital hygromas. Now, if someone has an occipital hygroma and you're doing a thyroid ultrasound, you're not going to see it because the occipital is the back of the head. All the way down to the base of the head is your occipital bone. But as you can see, like on this child here, she or he, I don't know, has a hygroma there. I mentioned trisomy 21, 18. There's also Turner syndrome. And that is only females who get Turner syndrome. But it's not actually only females that get Turner syndrome. They're the only ones who live. Male fetuses with Turner syndrome do not ever live. And even most female fetuses don't either. And when they do, they actually live normal lives. Salivary glands. I said it right that time, but I oftentimes really mess up that word. I think I try to say saliva and salivary at the same time, so I say salivary. But anyway, salivary glands. We have 3 pairs of glands. The first one is the parotid. And if you're looking at the parotid, you're not doing a neck. The parotid is all the way up by the ear. Even kind of goes up in front of the ear. That is the biggest salivary gland. You know what it is? I try to say saliva and salivary. That's what it is. Salivary gland. The parotid is the largest. 85 in this, and tumors are not that uncommon. I actually have a friend who had many surgeries in her life. And in fact, I never talked to her about it, but I realize now she most likely has multiple endocrine neoplasia. She's had 50 surgeries. A bunch of them were cancer. She's had a bunch of cancers removed from her body, a bunch of benign tumors removed from her body. And one of them was the parotid. So she's kind of has a dent on the side of her face where the parotid should be. There's also submandibular. You will see that with a neck exam. And then sublingual. You probably will not unless you're really looking for it. and that one is under the tongue. So let's just quickly look at this picture here. So with the parotid, can I draw on you? Yes. With the parotid, like I said, kind of on top of the mandible, all the way up by your ear. And that is the largest one that has the most tumors on it. But then the submandibular, when we're scanning with our transducer, we're going up, 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 up. We will run into the submandibular. We've actually, most of you have already seen the submandibular when we were doing carotid exams, because as you're trying to follow the internal carotid artery, the internal carotid artery is going up this way, and it's right near that gland. The sublingual gland, you have to be looking, obviously not under the chin here, but you can't see through the chin. Obviously, it's a solid bone here. But the mandible is a V-shaped bone. There's actually no bone right underneath your, further back from your chin. You can look up. In fact, you could look up all the way and look at your tongue moving. It's kind of creepy. But the sublingual gland is there. Now, both of these glands, when they're normal, look very much like a thyroid. Maybe not quite the same shape, but the echotexture and the echogenicity are very, very similar to thyroid. One thing that can happen is you get a stone in the salivary duct. And I was practicing saying this and now I've forgotten. Ciliodentitis. Yeah, ciliodentitis. And that doesn't refer necessarily to the stone itself. That is an itis, so that is inflammation, and the number one reason for inflammation of the salivary glands is a stone that developed in the salivary gland and got stuck in the duct and is now blocking the duct. And then I just wrote nodes. I kind of feel like we already talked about that. But when you're looking at the neck, this is really what you're looking for. 9 times out of 10, this is what you're looking for. This is what you're being asked to notice. Are there nodes? And let's just quickly remind ourselves what a node should and shouldn't look like. Let's go to a different color here so that on a transverse view, that's a good looking node. A long view kind of looks oftentimes, not always, and nodes could be a little funny shaped. The funny shape is not the problem. But they kind of look like a Mr. Peanut. If you're lucky, you even get a tri-lobe Mr. Peanut. Both will show a echogenic hilum. But if you get a very hypoechoic node and there's no hilum, that's a problem. And if it increases in size. Now, nodes in different parts of the body are different sizes. So you have to know that a neck node is not usually a very large node to begin with, whereas along the aorta, those are larger, and in the groin, those are larger. The other possibility for nodes too is focal thickening of a node can be also an indicator of some kind of infection or cancer going on. Perfect. 149. Any questions specifically on this so far? Okay. I'm glad I wrote it out. I kind of wanted to get through this a little quickly. Parathyroids are, once again, they're not exactly our #1 exam, but they are important to know about. So I feel pretty good about this, about the pace today. Cool. Take a break. We'll come back at 2:10, 10 minutes after 2. And let's see, I'm actually going to stop